Can everyone see the slides?
Yep, they look good.
Great.
All right. And Elena, I'll have you actually go to the next slide. Perfect. Okay. We'll get started right on time as we have quite a packed agenda. Welcome to everyone. We have many speakers today joining us. So rather than give a full bio, I'm going to give a very abbreviated introduction, and then people may present more context also as we go. My name is Dr. Kate Heyman. I'm an emerge doc. I'm the medical director of the Toronto General Emergency Department, and a member of both the GEM Center and the CAEP Health Equity Working Group. We're going to start off today with Dr. Alex Poole, who's a general surgeon and the founder of the Canadian Frostbite Network, who's been practicing in the Yukon for many years. He'll tell us a little bit about the history of frostbite in Canada and modernizing frostbite care in Canada. We'll then turn to Dr. Ian Walker, who is from the Calgary zone and was the chief of emergency medicine at Foothills when iloprost rolled out there. We'll turn to Heather Boucher, clinical nurse specialist with Alberta Health Services, who will tell us about implementation. We'll also hear briefly about how things went rolling out into the community in Red Deer specifically. We'll then turn to Dr. Neelam, who is the current site chief at the University of Alberta Hospital, and Donal O'Doherty, clinical nurse specialist with the Edmonton zone, to talk about implementation and community engagement. And then finally, we'll turn to Dr. Vince Gabriel, who is the medical director of the Burn Treatment Center at Calgary Foothills. And then we should have lots of time for Q&A. Elena, next slide, please. Very briefly, since we have you all here, the CAEP Health Equity Working Group was started several years ago before the pandemic as part of the Public Affairs Group, really with the goal of advancing health equity and social emergency medicine in clinical, educational, and academic environments. And we're interested in clinical care, but also in systems change, research, and advocacy. And then next slide, please. The GEM Center is based at the University of Toronto and is the Center for Global Equity and Emergency Medicine. And is focused on developing and implementing education and research initiatives informed by clinical practice. And so we think frostbite is such a fitting topic, not just because we're having this unusual weather in the East Coast, which it's a bit fortuitous that we all have the opportunity to learn from you, but really because frostbite care isn't just about good clinical bedside care. It's about how do you develop and change a system with a number of partners, particularly when the people most affected by the disease are people who experience a lot of marginalization. So really, really looking forward to the session. Thank you everyone for joining us, and I'll turn to Alex. And for all the speakers, Elena has kindly agreed to help us manage the slideshow.
Thank you very much. Thanks for having me. I'm not necessarily going to speak about the history of frostbite care in Canada. That would be an interesting deep dive for me to do at some point, which I haven't done. So I don't want to not give credit to people who may have done work in the past that I just haven't discovered yet. We inadvertently started this snowball of advancing frostbite care across the country by simply having a frustrated Google search back in the early 2010s, where I worked in Whitehorse. We occasionally saw bad frostbite cases, and I came to the realization we weren't treating them well, and also that probably people assumed we would know how to treat frostbite because we were in the Yukon and it's cold and we saw patients with frostbite. And I was a little surprised I didn't find a very cohesive approach to frostbite in the literature that would apply to us. So we made one that worked for us, and we recognizing that all the data for frostbite is pretty slim, we did everything that we could to find data that supported what we added into our protocol. And the big change that we did, other than actually having a protocol, was adding iloprost and getting permission to add iloprost. And then we were encouraged, since we were the first people in North America to use it for frostbite, as far as we knew, we were encouraged to publish our first two cases, which we did in the CMAJ. And that created a bit of a groundswell across the country of people with an interest in improving their frostbite care. And that's how I inadvertently became a frostbite researcher and an advocate for advancing frostbite care in Canada over the last decade. And that's really what's happened. And some of the other speakers today will talk about how they've built on that work. But that's really the short version of what happened in Canada. I can't remember if I have another slide at this point or not, but I think I'm pretty much done. If somebody else, oh yeah, and this is the protocol that we made. And our intention was to make it for us, make it very simple, easy to follow, easy to post in the emergency department so that we could do it. And it was intended for our center, which means we don't have advanced radiology. We can't do intra-arterial treatments because we don't have an angio suite. And so it really worked for us. And turns out it works for almost anybody who can measure blood pressure and give IV medication. So that was helpful. And I'll be happy to answer questions when we're done all the speakers.
Thanks, Alex. Whether Alex realizes it or not, he's pretty much directly responsible for the fact that we have Iloprost in Calgary now. So in the winter of 2017, I was actually on call for our air ambulance service, and I got a call from a colleague, a doc in Golden, who wanted us to airlift a patient from Golden to Whitehorse so that he could get appropriately treated for his frostbite. And of course, we weren't able to do that for a variety of logistical reasons, but what it did do was kind of spur us to make sure that the therapy was available locally. And the initial work, I will say, was actually done by our pharmacy team, who had to secure the drug through Health Canada. And we were actually quite surprised how easy that was. And in February of 2018, in the midst of a cold snap, we were simply told one day that the drug had arrived and was in our pharmacy. And so, faced with a couple of severe frostbite patients and an available drug, but no approved protocol, no agreements in place, we, sort of in classic Emerge Doc fashion, decided that it was better to beg forgiveness than ask permission. And so we just, in a somewhat cowboy kind of moment, just administered it using Alex's protocol, which we printed off from the CMAJ, to these patients in the ED, and then started worrying about where we were going to what we were going to do with them afterwards. The pharmacist actually had to enter the orders manually since there was no order set in our EMR. And then once the initial concerns were expressed about their hemodynamic monitoring, we actually had a very obliging intensivist who agreed to admit the patient to the ICU purely for the administration of iloprost. So we had a handful of patients in fairly quick succession during this cold snap that was probably not unlike what you're experiencing in Eastern Canada right now. And the hospital admin quickly became aware that these patients, some of whom were admittedly a bit disruptive, were taking up scarce ICU beds. So there was suddenly this groundswell of support for creating a protocol, because there really at that point was no longer an option of going backwards and not using the drug, since we'd already given it to about 3 patients. So we quickly developed a guidance document for the management of frostbite and some admission guidelines. Initially, most of these patients were admitted to internal medicine, and to specific inpatient units only, like the burn unit, for instance. But over the course of a couple of seasons, as people got more and more comfortable with the drug, most of these have been decanted to our hospitalist service and few of them will go to internal medicine only if they're sort of sick with significant comorbid illness. In order to allay some of those concerns about hemodynamic stability, which really has turned out not to be such an issue, we agreed that the first dose of iloprost was to be given entirely in the ED, in order to establish that the patient was safe and tolerating the drug well. And that continues to be the case. So next slide. So overall, our results have been fairly convincing. While not perhaps as dramatic as the results that Dr. Poole has published out of Whitehorse, we are also conscious of the fact that our patient population is somewhat different. Our frostbite patients are overwhelmingly homeless or housing insecure and struggle with addictions and mental health concerns. They also have significant medical comorbidities. This slide, though, summarizes our first 2 winters of data, comparing it to the 2 winters before the introduction of iloprost locally. So we analyzed the data both in terms of the number of patients requiring at least one amputation, as well as in terms of the total number of amputated digits. These graphs describe the latter. So what you see here is that we had no amputations at all, pre or post, in our grade 2 patients, but the amputation rate in grade 3 injuries decreased from 44 to 18%, and in grade 4 injuries from 95 to 46%. The effect was quite a bit more marked, particularly in the grade 3 injuries in the upper extremity, which arguably are probably more important than the lower extremity. But overall, this gives us a number needed to treat of well less than 2 in order to save 1 digit. So next slide. We would be happy to discuss our experience offline if anyone is interested, but some of the lessons we learned from our admittedly rather clumsy implementation were these. Although admitting services can be quite leery of adopting a new therapy, they very quickly came on board after a few positive experiences. Word of mouth really helped here, and the discussions that the internists and hospitalists would have amongst themselves was very helpful. I'll actually never forget one of our internists telling a colleague they were sort of huddled in the merge, and we'd asked one of them to admit this patient, and they were very leery, wondering if the patient needed to go to ICU. And the other internist who'd admitted a patient, similar patient, a week or two before, described it as a massive nothing burger, which then led to the patient being admitted without much ado. The support from plastics and ICU was very helpful in convincing our higher admin. But at the end of the day, this is a therapy that the ED can and probably should lead the charge on. Ideally, do better than us and have a process worked out in advance of implementation so that so you at least have some predefined protocol for the use of the drug, some order sets, and at the very least an agreement about who will admit the patients into what units. In our second and third unit winters, as our use of iloprost expanded to other hospitals in the Calgary region, and frostbite increasingly became a hospitalist problem, the data that we had collected over that first winter, and in fact, the first data that we presented locally was actually only our first 8 patients, but clearly showed benefit, was extremely helpful in bringing inpatient docs, nurse managers, and senior administrators on side. So if you're going to do it, collect the data showing the positive outcome because it will help as you expand out the protocol. That's it.
Thank you, Dr. Walker. So just to kind of go back to where we are now, we've had 4 iterations of our document. So now that we've been using this since 2019, December of 2019, the first document came out, we've done quite a few revisions. So one of the things that we noticed, and Donald will talk a little bit about the Edmonton experience, but in Calgary, we really know that these patients present to us through a variety of ways. So first, finding our patients. How do they get to us? They come to us from urgent cares, they come from shelters, they come via EMS from urgent cares, they come via private vehicle, they come via public transit or through the shelter transport to us, and they present in our emergency departments. And as Ian said, they are complicated patients often, and even knowing that they have frostbite is the first step to being able to help them. So these are patients who arrive with many, many layers and who often come with presentations that are unrelated to frostbite. So one of the things we've started doing, or that has been being done, is asking the question, do you have any limbs that you can't feel? Have you been exposed to the cold without adequate shelter for any length of time? So identifying the frostbite patient is the first step. The second piece, and Donald's done a lot of work on this, is really making sure that we have a good ability to assess their acuity. So our C-test for just frostbite with normal vitals only gives you a C-test 5. If you add in some pain, it goes up to a 3. And if you have altered vitals or a significant pain, it'll get you to a 2. But the reason that's important for us is that these patients are often sent to the waiting room to await their turn to be seen by our team. So if we haven't identified that they have frostbite, and if they get a low C-test score, then they often do wait for too long. So once we identify our patients that they have some degree of frostbite, what we have to do is rewarm them. And this is the most complicated, time-consuming piece of the frostbite pathway for nursing as well as for space allocation. So we can't grade or start further treatment until after rewarming. So we're trying to prioritize that. Knowing that the average rewarming takes 30 to 60 minutes, but if you have a large joint or a larger piece of body that is involved, it will take longer. And that's also dependent on what equipment you choose to rewarm the limb or digits in, and how frequently you're able to exchange that water to keep it at the right temperature. So there's a lot of moving pieces here that we find challenging. The logistics of avoiding the freeze thaw and ensuring that the patient gets completely rewarmed is challenging in a waiting room. So we have some tips and tricks for that, but this is a challenge that has been identified. Um, I'll show you a slide after about the equipment selection and how that can impact the actual delivery of rewarming. But like I said, it is the biggest piece for our nursing folks. When it comes to iloprost, as Ian said, initially when we were doing this, these patients were going to the ICU. They were placed and taking up space in the monitored area because we were unsure about how they would react to the iloprost, given that it's a vasodilator. We have since slowly over the last 5 years, I guess now 6 years, been moving the patients out further away from the monitored area as emergency departments become more familiar with the medication and we see very few to no adverse reactions at all. These patients are now in our less monitored areas. They're also sitting in recliners and getting this medication. And truly the only limit right now to being able to do this in a waiting area is the frequency of the vital signs. So for now, we are doing Q 15-minute vital signs for 2 hours and then Q 30 until we decide not to do Q 30. I anticipate that our next iteration of this document will include some discussion about changing those vital signs. I know from an inpatient perspective, it's also very time consuming to do 30-minute vitals on a patient for a prolonged amount of time. To align with the Yukon protocol, and because of some research that was done in Edmonton, we are now giving the entire 50 microgram dose of iloprost, which we were not previously. And this is given at escalating doses. So you start at 2 mics and you go up to a maximum of 10 mics for patients that are mics per hour for patients that are over 75 kilos. So you can see that this might take more than 6 or 7 hours, and keeping the patient in the emergency department for the duration of that is also becoming sort of a push. So I anticipate our next steps are going to be to have more discussion about the frequency of vital signs as well as how long we're going to be keeping patients. So as Ian said, right now, keeping the patients for the entirety of their infusion is really helpful to our inpatient partners, and they are very accepting of these patients right now. I think that we are also seeing a lot of patients get iloprost started at our urgent care centers, primarily those that are in inner city, and our EMS teams are able and happy to transport patients while receiving iloprost to our larger emergency department sites. So that's a really great there's a great working relationship there. There is still within the urgent care sites in the inner city some reluctance from some patients to come into the emergency department. So our next steps are involving our mobile integrated health paramedics to make sure that they can assist with either encouraging people to stay or maybe bringing them back for treatment. There's lots of options that are being explored. So can you go to the next slide, please? I'll just discuss, this is how in Calgary we have that frostbite bin that includes all of the bits and bobs that are weird. So the chlorhexidine glutamate with isopropyl alcohol that we can add to the water when we're rewarming, as well as that temperature probe and our current protocol laminated live in this frostbite bin. We just keep it all together. That I know some sites have carts, some people do different things. The other bit that I wanted to talk briefly about is the selection of the basin that you use to rewarm your patient. On the far right, that's just a massive biohazard bin that we use. It's just big and we can use it. The other two options really get cold fast. So that's where you have a lot more work. If you have someone who can sit on a chair and put their arm into a big bucket, great. If you have to use a smaller bucket, it causes more kind of work for everybody and a lot more water being spilled all over the place as you exchange it to keep the temperature. And that's it for me.
All right, I guess I'm up next. My name is Steve Frericks. I'm a pharmacist and I've practiced in the emergency department for over 20 years in Red Deer Regional Hospital. And I'm presenting on behalf of Dr. Tara Kumar, who can't be here today. So next slide, please. Some acknowledgements. We pulled some data from our Connect Care or Epic-based software, electronic health record information to share with you today. Next slide, please. So one of the things that we found when we were looking at ED encounters across Alberta from data from last year is that nearly 30% of ED visits were seen outside of Edmonton and Calgary zones. Edmonton largely seeing the bulk of the frostbite encounters in ED, and Calgary trailing behind. Next slide, please. And then about 16% of admissions last year were seen outside of Edmonton and Calgary zones. Next slide, please. And so really when we adopted the Frostbite protocol and the use of iloprost, we mainly adopted it in the Red Deer Regional Hospital, which is just a shade under 400 beds. And we service the area smack in the middle between Edmonton and Calgary. And we're a very large geographic area. We have 22 rural sites that we service. And it was originally designed for the larger sites because it's easier to keep the iloprost supply. Orthopedics and plastic surgeons, that's where they live. And it was easier to keep the educational component tight within our regional facility. But the current reality is that we're on overcapacity. Everyone's on overcapacity. When the rural sites were trying to move these patients to Red Deer, they were getting blocks and saying like, well, you have to treat them. So we have to treat them on site. So we just shifted and said, okay, let's set up our rural sites to actually manage these patients, at least, the grade 2s and the grade 3s, and maybe we'll make a decision on the grade 4s. Next slide, please. So just looking at iloprost admissions. So this is any diagnosis of frostbite where they were admitted and received iloprost. About 19% of the admissions were seen outside of Edmonton and Calgary zones. Next slide, please. And then when you were looking at, those that were admitted that actually received iloprost plus alteplase, there's quite a few of them in the south part of our province, which doesn't make a lot of sense to me, but I guess that's just how it shook down in 2023, 24. Next slide, please. And then how the practice looks, the emergency physician assesses and treats first, and they grade the injury and determine need for admission, and they're typically admitted under the hospitalist and family medicine unit. Next slide, please. Now, I want to talk a little bit, and this is a little closer to my chest, the rollout in our rural sites. So we have 22 sites, and these are smaller hospitals that have about 20 to 30 inpatient beds. So what we found with Health Canada with the Special Access Program is that each site had to sign off for their own supply of iloprost. We generally do everything as a hub and spoke model with distribution of our drugs, spanning from Red Deer out to our sites. But Health Canada didn't see it that way, and they wanted each site to sign off. So we didn't have much problem having physicians to uptake and sign off on these and take responsibility for the stock. The one thing that we found is that all sites had to restock alteplase because we're not using alteplase for anything other than massive PE, which is a rarity nowadays. And we're using almost tenecteplase as our thrombolytic exclusively for stroke and MI. So the cost to restock this alteplase is $31.68. Times 22 sites was around $70,000. So, that raised an eyebrow or two within our pharmacy leadership team. It's one of these things. Time is tissue. It's logistics are hard to get alteplase to a lot of our sites, especially if they're remote. So we had to stock it. One thing that we want to look at, and we're going to work with the folks at Yukon because they are looking at this as well. TNKs is a possible replacement for alteplase, and we're starting to see some data in USA and Europe. And yeah, Alex said that they switched to TNK and Whitehorse. So we are anticipating your data, and hopefully you'll share. Otherwise in the zone, our clinical nurse educators were hard at work, and they created education packages for our nursing and physician staff. Next slide, please. And these are our central zone visits for frostbite. This is last year's data. So really, when you look at the data, there's not a lot of visits that we're seeing in each individual site, but those sites like Wetaskiwin, Ponoka, Drayton Valley, Vermilion, those are the sites that have a little bit of a higher unhoused population. So it kind of follows that, and that's how we stock the iloprost. So we kept about 2 courses of treatment in some of those sites. Next slide, please. And then this is overall summary of our inpatient care. Next slide. And specialist consultation with Connect Care and our electronic resources is a little bit easier. We have systems that we can attach photos to the inpatient chart. So we're hoping that is going to forego the need for the patients to be seen on site in Red Deer for the specialty care. If surgical debridement is needed, orthoplastics will usually take over our patients, and then transfer out of zone to Edmonton or Calgary is pretty rare. Next slide. And take home points. We're seeing it throughout Alberta, including our rural zones. Time sensitive, so we're making sure our providers are comfortable with the protocols and making sure that the drugs are available to them, not only in the hospital, make sure they're available after hours, easily accessible. And even though some of the high-grade injuries can be managed in the rural sites with access to orthoplastics consultation virtually. And, you know, with current pressures in healthcare, we're likely to see more of these admissions in rural sites in the future. Thank you.
All right, thank you, everyone. Thanks to all the speakers for pretty much setting up the press, sort of the background behind where we come in from the Edmonton zone. So what I'm going to talk about a little bit is the challenges that we had implementing the Frostbite protocol and the utilization of iloprost and an adoption of standardized frostbite treatment in our zone. As many of you know, Edmonton is a little bit more north than Calgary or Red Deer. And as Dr. Poole mentioned, they've already had their protocol running for 10 years. Dr. Walker has been running their protocol for the last 6 to 7 years, 5 to 6 years or so. And we actually have been the latest adopters, really not even entering the whole realm of frostbite management until about 2023. And before I get into my slides, I'll just kind of mention some of the challenges that we've had getting to this point. So prior to 2023, while there had been some provincial work looking at a standardized frostbite order set and frostbite management, there was quite a bit of hesitation from our zone, mostly driven by different opinions by our specialty colleagues about the use of iloprost, the evidence behind iloprost, when alteplase could be used, when it wouldn't be used. And so we were sort of at a standstill. And I think at that point, we were still, as an emergency medicine program and group, still really deferring to our specialist colleagues to drive the management of frostbite. But around the year 2023, we were really hit with a lot of media coverage. So this was blasted out all over social media, all over the news about why the frostbite amputation rates in Edmonton were so high. And as most of you also know, one of the biggest drivers behind change is competition and challenges. And Calgary and Edmonton have notoriously been, you know, head to head in all types of competition, especially the Oilers versus the Flames. But this one was a big driver. Next slide, please. Frostbite amputations reached new high in Edmonton and was decreased in Calgary. So this was one of those headlines that really sparked a real deep dive into why this was happening. Why is it that our management in Edmonton zone was so discrepant from the management in Calgary zone, leading to these adverse outcomes for our patients with frostbite? And there are a few things that we'll talk about a little bit later on. Donna will look into a little bit more, looking at our houselessness rate as well as our substance use rate. But one of the biggest things that was noticed and very clearly advertised was that we were not adopting iloprost as a management strategy in our emergency departments for our frostbite patients, and that we actually didn't have a standardized frostbite protocol. And this was very evident when we had some cases that were presented that we actually had to look into of missed opportunities for patients who had delayed consultation, delayed transfers to our larger tertiary sites for plastics and burns treatment to even consider alteplase. So people who were presenting early on with frostbite, severe frostbite, but then actually not getting the care they needed within the reasonable time, within the 72 hours that was needed in order to be able to offer any advanced treatments. And so with this attention on us, and then the actual work provincially for frostbite management and standardization of a Connect Care order set, we really deep dived into how we could make changes in the Edmonton zone. Next slide, please. So just giving you an idea of why this sparked such an interest. If you look at the blue line versus the red line, blue line is Edmonton zone and the red line is Calgary zone. And this is the number of amputations from frostbite injuries. The trajectory of the amputation rate had been fairly consistent and was parallel between the two zones from start of 2011, based on this graph, all the way up until about 2020-21. And then there was a large increase in both zones for amputation rates between 2020 and 2022. But then over the course of the last 2 years, our rates skyrocketed and Calgary's basically settled and decreased. Next slide, please. And this really was the impetus behind the changes. How we approached this was we decided to take this on from an emergency medicine program as a larger zone quality project. So within our zone, our current zone now it's changed to corridor, but our previous zone when we implemented this change had 12 emergency departments, 6 of which are within the city core, and then 6 outside of our city. But we approached this as an opportunity for all frostbite management to change at all of the hospitals. We as a program took on the ownership of the frostbite management strategy. We actually engaged a lot of expert help from Dr. Poole's team, Dr. Walker's team, and they both probably remember us asking a lot of questions a few years ago about how they were able to take this on in their own cities. We really refocused the attention and the strategy of frostbite management from being viewed as a surgical problem to being more of a medical problem. And we were at that time also changing in terms of, let's say, changing of the guard in terms of some of our specialists, bringing on newer, younger team members who had already had experience in Calgary and other places where Illiprost was being used. And so we were able to identify some champions in our plastics and burns surgery teams, our medicine colleagues, family medicine colleagues. Pharmacy really helped us a lot in being able to drive being able to get Illiprost into our emergency departments. And then we had a very strong nurse educator component, driven by Dom actually, and Heather in Calgary zone to really, move this forward. What we did was we engaged all of our specialty services, including plastics, burns, medicine, family medicine. And then we actually started talking with our EMS colleagues. And in Edmonton and in Calgary, we have a program called RAPID, which is essentially they coordinate transfers of care for patients outside of the zone into the zone, and then movement around the zone. And then we also have the Integrated Operations Center, which helps essentially air traffic control where EMS goes for destination for patients who are presenting with different degrees of frostbite. And we had a very clear strategy in terms of where patients would go if they had different severities of grading for their frostbite. And as Heather mentioned earlier, we worked a lot on early identification at triage, asking appropriate questions to try to identify sort of frostbite within the context of patients presenting with other complaints, and then a very clear emergency nurse-initiated protocol for rewarming. And then the next steps will be, Dom we'll talk about it, engagement of our community partners. Next slide. Some of the biggest drivers of the increasing presentation of our frostbite is the number of our houseless population. So in the last year or so, we've actually had an increase of almost 3 times in our unsheltered population in the Edmonton zone. Next slide. We are currently at our highest record number of houselessness in a season this year of very cold weather. Next slide. And then the other thing that has really increased for us in the last 3 years is the presentation of substance use into our emergency departments and transfers by EMS for acute drug toxicity. Next slide. So this is data that has been collected over the last 2 years since we implemented our Frostbite protocol and the use of iloprost and alteplase. So some of the things that really have been highlighted is even in the last year, we've had a surge in our houseless population, as well as a surge in our substance use presentations. Next slide. Now, one of the things that is really key to note is that our patients who experience houselessness are at a higher risk of presenting with delayed presentations to the emergency department. So both housed and houseless populations, there's a similar number of them who present within 12 hours of acute frostbite injury. But if you look out to the patients who are presenting much later, the large number of them are houseless. Next slide. And the severity of our patients who are presenting, who are identified as houseless for the frostbite injuries is also much higher. Okay, and next slide. And I think this is actually a really interesting slide that highlights the fact that, I mean, we always associate frostbite injuries and severity of frostbite injuries with colder temperatures. But one of the things that came out of our data is that we are actually seeing a high number of grade 4 injuries at temperatures that are not what you would classically consider to be cold. So if you look at that, the frostbite grade 4, so that would be the brown line, and look at the x-axis of the temperatures, we are actually seeing grade 4 frostbite injuries at temperatures as warm as -5. Okay, next slide, please. So I'll hand it over to Don.
Yeah, thank you, Dr. Lamb. And so when we looked at our data, we looked at the outcome actually from iloprost versus non-iloprost, and we did a replication study and found very similar to Calgary's experience with digit salvage, not as good as Whitehorse, but definitely a benefit with iloprost there. And we also found a potential signal towards an improved outcomes with an increased dosage. And that was one of the supporting factors that kind of allowed us to move towards what Whitehorse is doing, which is providing a 50 mic dose. But from a consideration of primary prevention, and so very quickly with the data that we looked at, we kind of realized that there's a significant upstream impacts there. So we reached out to some colleagues, actually Dr. Michael Zachary is actually on the presentation here, which is one of our local MOHs, which we reached out to for support and suggestions, and we're working with them. One of the considerations is whether this kind of classifies as a public health emergency. Is kind of getting to that point where we're not aware of any cases, any higher cases anywhere else in the world, and so whether that has significant morbidity, mortality. From looking at this, the delay presentations from trying to get folks in earlier, and so then you're looking at a community press, and so you're looking at we've had meetings with the city, with our MOH colleagues as well, to look at, we have a current cold weather, extreme weather response with the city of -20 after wind for 3 days prior to activation. So we're suggesting maybe not going as much as what Vancouver does, which is 0 degrees, but something around that -3 to -5 mark, which is what we're seeing. And also looking at supported for increased support for our current cold weather response, because 70% of our cases occurred during an organized city cold weather response, and we still get these cases. So looking at what else we can do to support the prevention of frostbite. When we're looking at decreasing the time from injury to hospital arrival, then we're looking for community partners. So we're looking for our shelters, EMS, to be supporting cases. So, for example, if EMS turns up to an opioid overdose, that the patient is happy to no longer need transport to the hospital, we're suggesting that would be a reasonable place to be screening for, can you feel your fingers and toes, and if not, can you get you inside and take a look at those fingers and toes to see if we can get you in. But it takes definitely it's a slow process to get that going. with our community partners, some of our community folks have implemented a community wound care tool that's for non-healthcare providers to try to consider frostbite and acute frostbite as a medical emergency and get the folks in. But I'll share that in the next slide. And then there's also a role from a community prevention point of view of the role of intoxication and substance use and the safe sheltered places for that, because we have not all of our shelters, most of our shelters are dry. We sometimes don't have good places to be smoking outside at minus a billion. And we don't have, yeah, and so from that point of view. And go ahead with the next slide. And so this is an example of the community resource tool that was set up by community partners. And it's a wound care tool, so it includes various different wounds and assessment, and it's designed for the outreach clinics and for screening in the clinic. So any of our shelters and some of our clinics use this particular tool. And so this will be the first page of it, and then go on to the next slide. And this is the section on frostbite, which is basically low risk, moderate risk, high risk. And high risk is when you've got signs of ongoing ischemia or frozen tissue that basically needs to come into an emerge in a timely fashion. And so this is that. And I think next slide, and I think hand it over to. Oh yeah, Edmonton experience. So yeah, very similar to Calgary in terms of implementation. As we say, pharmacy has been key. We've actually had the benefit of pharmacy does the tracking, the special access tracking behind the scenes. So the front line don't need to fill out any forms. We've actually got it computerized computerized in our system, so it's automatic. So they can pull the information automatically. So that was a key finder, and there's some potential learnings to expand that. We did find that when we started paying attention to this as something that we need to take timely action on, in the context of an overcrowded emerge department, our nursing staff in particular had to be supported through moral distress during implementation when we're asking folks to try to meet timelines to get a bucket of water and an analgesic for these folks. In the context of 110 people in the waiting room, that's a with 20 life-threatening cases. That's a challenge, and so we kind of have to understand that we're still triaging care, and this is a limb-threatening injury versus a life-threatening injury. But we have to be aware of that. When we did look at the pathway, we did pathway impacts. We got an improvement in GCS. An improvement in CTAS, time to immersion rewarming, and increase in Illipos use. I think 2 cases previous to 23-24, and then I think 160 cases last year, and I think we're at 168 cases this year so far. There is an increased use of work on the floor for Illipost, and our inpatient GIM partners are certainly partners in the process. And we are looking at an outpatient pathway. We don't have a lot of European adventure races, as Dr. Poole likes to call them. I think we've managed a couple of patients so far working with our colleagues and IV therapy. But again, it's a complex patient population that have medical needs. Thanks. Next slide. And I think that is, yeah.
Thanks, everybody. So looking at frostbite as part of the portfolio patients that may benefit from treatment at the burn center. Historically, maybe burn centers have kind of by default been places for frostbite to go, since it's a thermal injury and sometimes it's complex soft tissue injury. But we have some considerations. Just as a little bit of our catchment, Calgary zone has been experiencing a significant overall increase with about 19.5% year-over-year increase over the last 5 years. However, let me take the next slide. For admissions, just for burn injuries alone, preceding 2020, it would be very unusual for admitting more than 100 patients to our inpatient service. But we've had a rapid and sustained increase since then. So these last few years, 2023 was 193 admissions, I believe. 24, about 145. 2025, we just took a look at about 156 burns. So let's take the next slide. So the thing with burns is they may require an immediate surgical intervention. This would be true for some other what we consider burn adjacent diagnoses, like necrotizing fasciitis, that we've also been seeing an increase in. So one of the things, if you look back at, considering those previous two slides, the increase in rate of severe burn injury is greater than can be explained by population growth alone. So our incidence is increasing. Yes, part of it can be explained by the changing socioeconomic demographic. However, even just growth alone, changing population, either in Calgary and Edmonton, we each site only have 8 specialized burn surgery beds. And this has been fixed prior to 2000, I should say. So our acute surgical beds are a scarce resource. So makes sense for us that really it's the cases that need a surgical intervention or another complicated scenario, the acute frostbite grade 3 and 4 that are undergoing acute treatment, are places where we could offer service that would be sensitive to our resources. And then we recognize, though, there may be complex wounds and issues around community reintegration that follow the medical management that's been discussed so far. So in the next slide, our allied health wound care teams have been working and recently rolled out this document, which is about the rehabilitation recommendations for the adult with severe frostbite. And this goes through a variety of things that community-based or hospital-based physio, occupational therapists, wound care teams can refer to that would both complement the acute medical management, but also to facilitate functional return in the community. So in the next slide, I think it just from our perspective in the burn center, we think that the most treatment options at the right time by the best provider is our philosophy around frostbite management. We recognize that burn bed units are fixed, and despite our expanding and changing population, and that the thrombolytics, anticoagulants, vasodilators are chapter 1 of management of the frostbite patient. And so the ongoing supports and integration of allied health professionals can facilitate the return or at least potentially minimize long-term disability for this vulnerable patient population. That's all for me. Thank you very much.
All right, so Alex, I don't know if you want me to chime in here at this point, but I might as well since nobody seems to be stopping me. Okay. So, man, that was a great presentation. This is what at least a dozen years ago, this is what I really hoped would happen is cities such as Calgary and Edmonton and Winnipeg would get interested in modern frostbite care because I speculated that these were our big cold Canadian cities that also have world-class research facilities. And I suspected they had a lot of cases, and turns out that that's true. And I think that is going to be a game changer in the world of frostbite care and research, is having, in particular, Calgary and Edmonton involved. And turns out Winnipeg is a bit of a iloprost denier, which is going to be great because they'll be the control group. So that's good. So I like to tease them about that. But we certainly have a lot of things to learn. And I agree. One thing has evolved in the larger centers is that the emergency departments own this. And I think that that's where the initial care needs to be owned. It would be nice if we had a frostbite registry across the country. Granted, I mean, Edmonton's numbers alone will probably dwarf the world's literature of cases soon, but if we had a national registry, I think that would be helpful because we have questions that we do need to answer. One is I'm not even sure we need thrombolysis in the grade 4 cases. If you look at the publication 2011 that started the groundswell of iloprost in Europe from the New England Journal article, their grade 4s that got both actually did a little worse than their grade 4s that just got iloprost. So there is a possibility that if you're giving iloprost, maybe you don't need to give a thrombolytic. So a study looking at iloprost versus thrombolytic versus the combination would be good. I think early evidence out of Edmonton suggesting that there may be a dose response, and we may be able to refine this further. I mean, truth be told, it's somewhat arbitrary now that we give 6 hours for 5 days or the full 50 vial, and how long we should treat them. And maybe, especially with your homeless population, if there was one big dose they could get once that was helpful, and because they may not come back to the hospital, that would be useful information to know. So we still have a lot to learn, but we've certainly come a long way in the last 10 years. So thanks everybody for all the work you've done. It's been a fun journey, and I think that we will eventually get there. We have created a Frostbite Care Network. I'm not the founder, I'm one of the founders, and Domhnall is on our team now, and we're trying to keep, we have a website we're trying to keep up to date with the latest information for both providers and for patients. And there's educational materials there too that may answer some of the questions that were in the chat. And I'm certainly happy to participate in any further questions and discussions if anybody has them.
Thank you so much to all of the speakers, and for the tremendous work that you've all been doing. This work has inspired us to improve our frostbite care at UHN, and I'm actually excited to share we have successfully given someone iloprost, which thanks a lot to the work of one of our ICU colleagues, Dr. Brooke Tillman, who I think connected with some of you directly to help build our not yet formalized protocol. But really, thank you for doing all of this work so that we also could be prepared in such a cold year. Thank you also. There's a number of people answering questions in the chats already. I think many of them are addressed. If anyone has any question, they'd like to raise a hand, and now is the moment. We have a couple of minutes before we wrap up.
I'm happy to answer the grade 2 question because I get that a lot. So in our initial protocol, we treated grade 3 and 4. The main reason there's 2 reasons we treat grade 2. One is that the iloprost was incredibly well tolerated. And then the data that came out of Minnesota showing that time matters, they had over 70 patients, and they demonstrated, they just used thrombolytics for this, that every hour delay after rewarming treated the patient increased amputation rate by 28%. And I have seen a lot of patients where I'm very convinced of their grade at 24 hours, and it's worse than it looked right away. And so I hate to miss a grade 3, and particularly in the hands. And so that's why we started treating grade 2. The combination of I'm scared to miss a grade 3 in the hands, and the iloprost is really well tolerated. So that's why we decided to start treating grade 2s. So you can make a judgment call. If they're really far out from their rewarming and it really convinces a grade 2 in one toe, then maybe you're not going to treat them aggressively. But we thought it was easier just to do that, and that's why we made that change.
I would say from a Calgary perspective, we've had the same take on it. And the reality is that the iloprost is cheap if you get it from Health Canada. I think it's actually still free, but Steve can correct me on that. But even if we paid for it, it would be cheap. And the vast majority of these patients need to come into hospital for other reasons, right? So it's not like you're admitting them to give them this drug. They're getting admitted anyway, and then you give them this drug that is incredibly safe and low risk. So it is a bit of a why not, recognizing that a small percentage of them are actually going to be worse than they look like they are at first.
There's a question in the chat about grading injury that is not on the extremities, so face, ears, other parts of the body. I'm wondering if someone could address that.
The short answer, we don't know. The grading method we currently use is based on fingers and toes, on bone scan studies done in Chamonix to try and develop that grading protocol. You can borrow the superficial and deep from burns to do that. It's really only significant probably on nose and ears, because if it's on the torso, chances are the ultimate treatment of just excising and closing is what we found successful. So these aren't limb threatening. But I use cyanosis or hemorrhagic blisters as my form of grading. And if it was a significant nose or ear with hemorrhagic blisters or cyanosis, I would probably treat them as a grade 3 and treat them. The other issue, it hasn't been asked, but is pediatrics. They may be a little different. The only currently published protocol that we found is the Children's Hospital in Calgary again, so gauntlet toss there for Edmonton. Uh, Truth be told, I trained in Calgary, so I'm well aware of how this rolls out between Calgary and Edmonton. So with kids, anecdotally, I've been involved with some cases where they didn't look as bad as adults and they had bone growth abnormality because of the injuries to the epithelial plates. So I think that there'll be slightly different protocols ultimately for kids than adults, but stay tuned.
I think there's a great pediatric reference from Alberta Children's that suggests a more robust treatment considerations. Don't believe Edmonton's recently had any grade 2 severe cases. Calgary's had a recent publication on their experiences of that with the PEDS folks. But I would recommend going to that PEDS resource. That is probably the best out there in terms of the consideration.
Yeah, there's a particular pediatric intensivist by the name of Simon Parsons in Calgary who's got an interest in this and has a very aggressive approach to it. Like he wants to use TPA in these patients. And he's also more than happy to talk to anybody who wants to reach out to him. He's looking for partners in this.
Thanks. Francesco?
Yeah, thanks. I'm a physician, medical director of an inner city clinic in Edmonton. I'm just curious from the non-Edmonton sites if you've had any success kind of using your experience treating frostbite in terms of leveraging better support on the preventative side. So, influencing other ministries or agencies responsible for housing because sometimes we're seeing clients repetitively going to the emergency department with frostbite injuries, separated by a matter of weeks because they return to the streets. And so have you had any success using your experience, especially for those of you doing, using this protocol for longer, influencing the kind of the housing of the homeless?
Maybe I don't know if David Klassen's on the line here, but he could potentially answer this question. But the -5 sort of delineation that DOMS kind of found and Neelam found in their data was used in Calgary, at least for discussions around -3 for this year. Okay, fair enough. Was used in discussions for creating warming shelters in Calgary. And for advocacy around that. And there was some discussion around with Edmonton. I don't know if like Michael can speak to that piece, but it's again more of a Calgary thing. But again, I don't know if Dave, are you on the line by any chance?
Maybe I don't have anything to add to that, Monty. Thanks.
Okay, last question to Michelle, and then we'll wrap up.
Oh, I was just going to add to that. Hello, everyone. I'm Michelle Podmore. I'm with ALA now. I moved from AHS and oversee the social workers, which we've just joined provincially. So we've been making some connections with ALSS and the ministry in which the shelters are overseen provincially. So perhaps there's some connections that we can make following this, just listening to the high rate of the unhoused population and the higher risk. So I think they'd be very open to more conversation if some of it hasn't been had.
Thanks, Michelle. Thank you again to all of our speakers, to everyone for attending. Our next webinar will be on April 30th, 12 EST. And please save the date. Please also use the QR code. We have a couple of potential topics for discussion, and then we'll get organizing on the session. This has been incredibly fruitful for me, I know, and I think probably one of the sessions where I've had the most sort of simultaneous systems change leaders on a call. So I really appreciate all of your time and hope everyone can stay safe and warm out there. Thank you.